Part of the African diaspora story is that there are many people that are doing incredible work. Some work goes sung, some work goes unsung. Now, today I sit down with Edwin Ndlovu MBE, who is part of those that are sung heroes. He was recognized by the royal family for his incredible work and contributions to the NHS Trust here in the UK, specifically the East London Trust, from which he runs a staff of 7,000 people, including a budget of 650 million UK pounds. Now, I sit down to learn about his incredible journey and what insights we can gain so that we can actually pivot the diaspora to better our services within the African continent. Welcome to SAT Interviews. I am your host, Farai Ian Muvuti. Enjoy. Thank you so much for joining me, Edwin. And it's such a pleasure and an honor to sit down with you in light of your recent achievements, which we'll go into. But let's start from the beginning. You were born in Zimbabwe and you migrate to the UK. How does this journey begin from all of a sudden an engineer from Zimbabwe, and now you come here as a nurse, and now we see you at this top level of leadership? How does this journey begin?
Thanks very much, Farai. So where do I start indeed? Born and raised in Masvingo. In fact, Masvingo is still the home. That's where my parents are. And I would say it's probably them who did more of the encouraging to try new things when I'd finished my engineering.
Okay.
Because at that time, career prospects were not looking that great. They said, well, look, at least they had the means, plus also the wisdom to say, take some time out, do a bit of traveling, go and see the world. And, came to the UK because that's where I had a lot more relatives, so it was easy to come to and settle into the rhythm of things. And decided to try my hand at nursing simply because my father had done a lot of work with the Red Cross during the Liberation War.
Okay.
My mom, although she's a teacher, had also done quite a lot of the domestic science stuff. So I came from a family of people who had been in the service to others way of thinking. Mm-hmm. And who had been in the caring professions. And I could trace people back to my paternal grandparents as well, nurses and all. So I guess it was in the genetic makeup to try a bit of nursing. And then I didn't look back after that because it just felt like the perfect fit, I guess, for the person that I am, my demeanor, the thoughts I have around how to connect with other human beings. And one could say perhaps the rest was history. It just became a career that just not only allowed me to grow as a person, but as you have right now acknowledged, and thank you very much, I've also been able to be quite successful in it in terms of my career aspirations.
And so what were some of the sort of, be it mentorship or be it programs that helped that particular pathway to where you are now in terms of leadership? Because I can imagine coming from home, for myself, for instance, having come to the UK early 2000s and so forth, trying to find your path and getting a sense of what the best way forward would have been. It would have taken quite a lot of guidance, a lot of networks. How do you then find that path?
I suspect that a bit of it is, as I've alluded to earlier, I've been described as somebody who listens very carefully to what your elders tell you. So there's a bit of that. The second thing you rightly mentioned, there are mentors, and they're just people you work with who are guiding lights. And I've been fortunate enough to have worked with people who took me under their wing, helped me to grow as a nurse, and then when I went into healthcare leadership as a healthcare leader, I work with a phenomenal team of the executive directors who are people who I have huge respect for as individuals and also as colleagues. And I've learned a lot from them. And so I've been quite eclectic in where I've received my guidance, my support, my mentoring. But ultimately, I have to put my parents at the center of that because I don't think that without their guidance and their kind of, the stewards of those values, I wouldn't be perhaps the person I am today.
So you do point to the nursing aspect of it, which I think is important, maybe to dwell on that. Why nursing as a pathway?
So firstly, why nursing? Because I was encouraged to consider nursing.
Oh, part of the listening aspect
Yes.
you were talking about, right?
Absolutely. Because when I came to the United Kingdom, I was already a qualified mechanical engineer, fitter and turning. And my aunt then said, look, I can see you're trying to get into this field and you will get there, but for now, why don't you try this? Because I can see there's also a bit of frustration in, because it was taking a bit of a long time to get into the engineering space here in the
So you
United
had to adapt.
So I had to adapt. And I think maybe I did it with a lot of hesitation, but at the back of my mind, I had that inkling that my parents have done well out of this. They've raised me. My aunt is doing this. She's encouraging me to consider this. I considered it. And Farah, if I tell you that, the moment I made the decision, even to get into a place to do nursing, back then it was Project 2000, and I think they don't do that type of training anymore.
Okay.
It was very swift. So maybe there was something, I don't know, the powers that be had decided that was the right path to take, because from the moment I made the decision to getting onto the course, it was less than 3 months. And the rest from that point on was, is history. But yeah, there was a strong focus on people encouraging me and me taking the time to actually listen to what they were saying and considering it in the whole scheme of things of what I also wanted to do.
Wow, so that's quite incredible, given the fact that there's a strong cultural tradition of the relations between those that have come before us, be it in the context of your aunt, and sort of giving that particular guideline. And so, I suppose what it leads me to is the clinical arena. You, of course, go into clinical care as a nurse, and now you're there. What then encourages you to then think about going into leadership systems where I suppose the element of being an agent of change, given that experience, provided the experience in clinical care, what then leads that particular transition? Do you actually walk away from clinical care completely, or is there something that triggers you to engage with the system directly, as it were?
Yeah, good question. I've not walked away completely from clinical work. So I'm still a registered nurse with the Nursing and Midwifery Council here in the United Kingdom.
Okay.
And the work that I do as Chief Operating Officer for East London Foundation Trust still involves, a significant part of it anyway, is to work with clinical colleagues in delivering the services that we deliver. So my clinical background, I think, helps me to do that. I think a part of it as well is that having had the hands-on experience of actually being a nurse, the one thing that nursing, I think, helps somebody to do as a nurse is that from day one, when you walk onto a ward or any clinical setting, you're already leading. Because you could be a shift coordinator, you could be a nurse in charge of a bay with X amounts of patients who've got different needs, and you're having to listen to each of them and coordinate yourself in order to provide the care. So you're already in a position of leadership. So again, I think as a nurse, it felt natural for me to then evolve. And again, those mentors I've described, the other senior managers I was working with, played their part in encouraging me to take on more responsibility within the clinical space. I think for me, it was 2010, that's when I made the biggest decision of actually saying, I would like to go into more formal leadership within healthcare. And at that point, I wasn't sure whether I would stay as a clinical leader, so follow the director of nurse route, or go into general management, which is where I am now as chief operating officer. I did do a bit of director of nursing for a bit. Didn't really feel that it matched my hands-on approach and my eagerness to be at the center of the action.
Okay.
And so I followed the operational or general manager route. And then again, I found that my clinical skills were still very much part and parcel of what I was doing. And even now, as I've described earlier, they still remain, the mainstay of how I lead as a chief operating officer.
And quite interesting as well. So you clearly have a sense of self-awareness at this point in time. I think, which is great insight for people like us who are young and trying to learn more about how best to work in emerging systems, or developed systems themselves, and find our footing, as it were. So you had a strong sense of network, firstly, with through the mentorship, then equally a sense of self-awareness, which I think is critical. Now, you currently lead a £650 million trust, right? And with an incredible, I think, 7,000 employees under your staffing,
Yes.
right? That's quite an incredible number. Tell me about sort of some of the transformative projects you've led within the mental health care system.
So I'm sure you're very aware of the changes we are going through in the NHS currently.
Yeah.
Yeah. So those don't pale into insignificance considering all the other bits that we've done. So
Sure.
I've led amalgamation of services. At the time when the NHS was in a different place and competition was being encouraged, I've led the bringing together of different services to increase what East London Foundation Trust's overall budget and size was like. And that involved taking on not just mental health services, but physical health care in the community. And then subsequent to that, as healthcare has changed, there were moments when male and female service users would be cared for on one ward. I led the transition to single-sex wards for my organization. And then more recently, it is the transformation that we are doing to try and make sure that we are living within our means. Essentially, that 650 million needs to go a long way to serve the population that it is intended for. And that involves reviewing our clinical pathways, reviewing how our workforce are designed and they are working, and more importantly, how we work with other statutory organizations within the spaces that we are delivering care in. So I'm talking about local authorities, the acute trusts, and the wider communities. So being Chief Operating Officer gives me a carte blanche of all those things. In fact, I've got license to interfere in almost everything, but I don't. You need to be respectful, of course. And at this level that I'm at, it's also appreciating that you have to lead through others. So there is the bit in me about facilitating transformation, changes across organizations, and then the whole integrated care and partnership working space. I would say as well that over the years, in my earlier years, the biggest transformation that I could say I was most proud of and I still talk about is the whole violence reduction work that we did in our wards. Because in mental health, violence is a big challenge.
Right.
It took a long piece of work to get it to where it is now. You still have pockets of violence, but compared to when we started, data definitely shows that the work that we've done has greatly reduced the violence on our wards.
And that's quite an interesting one. Thank you so much for the insights there. Now, how did you approach that, given the outcomes that we're currently witnessing?
My organization made a decision back in the late 2000s to adopt a way of improving care which focuses on quality improvement methodologies. And we went into partnership with Institute of Health Improvement to start doing this work. Part of it was at the start really collecting all the data of the big issues that we think existed in our organization that affected patient care, safety on our wards, and staff morale. And we did this by canvassing our staff and patients. So the violence and aggression reduction work actually came from our service users and staff, the most junior staff, to say this is an area we need to tackle. Quality improvement methodologies allowed us to start really focusing on what our data was saying around violence on our wards and in our community services as well. And then collectively, what it also then started to do was to give us a language that I, as an executive director, could have a conversation with your most junior member in a clinical team about what their team would like to focus on when it comes to violence reduction. And there was a multitude of things. Different teams were doing different things. And it took the best part of 3 years for us to get to a place where we had now a collective understanding of what our approach to violence reduction looked like. We had a collective understanding of what our data was telling us, where we started from, what the problem or problems were, and how we're trying to address them collectively. And we're now in a position where we have got a pack, we call it Violence Reduction Pack, that we've shared with loads of other NHS organizations as well to help them also on their journey to hopefully improving the therapeutic environments, because we know violence and aggression it's not only the negative impact it has on our service users, but it's also for our staff, because no one wants to come to work in an environment where you can expect to be assaulted, shouted.
And there is that stigma associated to
Exactly.
mental health as well.
Exactly.
That may deter students. And
Absolutely, absolutely. You're very right on that in terms of future employment and workforce. So it's a journey we're still on because it's ever evolving. And it's ever evolving because actually it's work held at local team level. So I'm talking of a ward actually leading their own work around violence reduction, or a community team doing their piece of work.
And there's a model you mentioned, a quality improvement model, you said. Yeah. Can you unpack that for me? What does that look like practically?
Well, practically, it's all about starting off with what your data is telling you. So you would need to, first of all, really have a good understanding of what sort of data sets you have and what do they tell you. Then it is about how you're engaging with your workforce and your service users. It's a bottom-up approach, but then what your data does is to augment what your frontline staff and service users are saying about perhaps their experiences in the workplace.
Gotcha.
What it then also does is to give you the tools to start testing out ideas, because believe it or not, the very people who tell you we have a problem here, 100% of the time they also have a solution and they know how to get to it. And the quality improvement methodology gives you almost a scientific way of now starting to understand the problem and quantifying your approaches to how to resolve that problem.
So this integrated approach, is it correct to call it that, an integrated approach, would you say?
I would say it's a co-produced approach.
Co-produced, bottom-up.
Bottom-up approach.
I get you. Yeah. So community engagement is a huge part of your work.
Yes.
And we've seen a lot of pressures, especially if you're looking at UK media, when it comes to looking at the NHS and part of the performance issues there. Now, tell me how that sort of the introduction of virtual wards and the integrated approach that is mentioned in a lot of the work you guys do. How does that look like? What has been the impact, and how are you seeing it for the future?
So virtual wards and integrated care systems are not mutually exclusive. Okay. Because I guess sometimes people talk of them as individual entities, but in my experience, the two are very, there's synergies there that are really important for the two to be able to give you what you need. Virtual wards, it's a very simple, I say, but it's an approach of trying to keep as many people at home or in the community. It's a way of making sure that you are reducing not only the cost, but we know that usually when people end up in hospital, so many other things start going wrong. And then that extends their stay in hospital. If they are older and frail, we know that then it starts affecting so many other things, their confidence to mobilize and amongst other things. So actually keeping someone at home is not only cost effective, it is better for their health outcomes. Right. Integrated care just means that we, statutory organizations, including some voluntary and charity sector, come together around that virtual ward. The ambition and the aspiration is that we are doing things in a one-stop shop sort of way. Okay. We've both got access, or all of us have got access to data sets that speak to what the service user needs. And it just helps us to economize on who's doing what for that individual. In terms of the outcomes, as I said, if they're both working well together, it's positive outcomes. You are keeping people at home. Or if people have to go into hospitals for the shortest time possible, right. You are making better use of your resources because you're not double counting social care, health, voluntary sector. You have ways in which each of those points of contact are counting to one individual patient's needs. And it's interesting because I think when I was growing up, community care in Zimbabwe was a thing. Right. I mentioned earlier my dad was in the Red Cross. So, when I've been involved in it, in my mind, sometimes you go back to your yesteryears. I could remember the district nurses. I could remember, going around with my dad and, visiting kind of community clinics where you would have on a weekly basis, someone from social care would be there to talk to people. You'd even have someone from the Ministry of Labor at one time where I grew up. And in a way, that's what's being mirrored by integrated care systems and the virtual world spaces.
And does that help with the sort of reducing the amount of people that are actually coming directly to the hospital? given the fact that, I know infamously part of the UK election was premised on a big topical issue around the NHS, which talked about the amount of people that were failing to access healthcare, be it from operations, be it critical care needs and cancer research, and so forth. Now, do you think that has been helpful in that regard?
It is making a difference.
Okay.
I guess the tricky thing with the NHS is that when you look at issues around access, if you compound all of them, people have challenges for accessing services in so many different ways. So we need to be really careful that we are also going to great lengths to try and differentiate why somebody might be struggling to access so that we can better help them.
Okay.
I think virtual wards for the populations that it's mainly intended to support, it is making a difference in systems where the integration is working well.
Okay.
There will be some systems where perhaps...
Oh, okay. That's why you said it can't be mutually exclusive.
Yeah, absolutely. Right. In my experience, those things have to work well together. Okay. But the waiting list that you're describing, I think there's a whole heap of issues post-pandemic and the whole unsettling of society that came out of as a result of the pandemic is contributing to some of that. And then, of course, in mental health, I think it's also important we recognize mental illness and mental well-being, what those two mean to people. Because sometimes mental ill health compared to mental well-being gets played out differently for individuals.
Right.
But people end up wanting to access services. So it's about what support and help they're getting. So part of what we are looking at the moment is how do we do a lot more of that upstream work. So talk about transformation, how we live within our means, that 650 million you're describing. Mm-hmm. How do we do a lot more of supporting people in the community so that they don't feel the need to end up in an emergency department or using one of our crisis pathways?
Okay.
And in doing that, we hopefully start to then reduce those waiting lists. You start to reduce the need for people to use the more expensive end of our services, which is inpatient care.
Well, incredible insights there. I suppose it leads me to, and you so rightfully mentioned your historical experiences back home in terms of the community. And yet, if we look at Africa, Zimbabwe, where you're from, there are significant challenges within the healthcare systems there. My question is, as one who is part of the broader diaspora, the African diaspora, working here successfully, one has witnessed, what would be your insight? How best can we leverage and pivot some of that skill set that you have, that experience that you have, to support some of the ailing systems back home, as it were?
I guess my first point of reflection is that we do need to also look at the positives in our systems back home in Zimbabwe.
Sure.
One being the healthcare workforce in Zimbabwe, and maybe in some of Africa, are probably some of the best trained healthcare professionals in the world at the moment. Yes, there are challenges around how these services are being financed, the challenge around the infrastructure. But I think we've got a workforce there that is very adaptable and highly skilled. So something to build on.
Okay.
I think the next reflection I've got is that there are opportunities to learn from how the UK system is approaching some of the challenges they've got. So I've described at the moment, yes, I'm talking about my organization, which is small, but the whole NHS is having to try and work within quite a much more confined budget.
Right.
It means that we're having to look at things, as I said, what are we doing upstream to try and do more of that preventative stuff? How are we kind of focused on keeping people in the community a lot more?
So you're having to find innovative ways to still work within that budget.
Absolutely.
Okay.
In Africa, those ways of working are there.
Day to day.
Exactly. So there's that kind of reciprocal learning that might need to be taking place here to help us with this. I think what we then need to also focus on is, in the UK at the moment, one of our biggest focuses on doing that work that I'm describing is focusing on neighborhoods. So you're talking of in a borough, X amounts of a population, how we work. And we know, speaking in Zimbabwean terms, at a district level, people know who's in their district and how well mapped out those districts are. So maybe there's something there about how do we start to go down to that district level and empower at a district level people to think differently about healthcare. So your municipal clinics or your city council clinics, they used to be a thriving hub in a community.
Right.
How can we bring those back up again and kind of make them the point of a community's health focus? Which takes me on to primary care. There's a huge focus in the United Kingdom at the moment around enabling primary care, so your GPs, general practitioners, to do a lot more. I would say it's the same in
More devolved system.
absolutely.
Rather than a central hospital.
Absolutely.
Sort of approach.
How do we devolve? Because when you look at some of the healthcare issues in our country, I know lately there's been a significant challenge with things like cancer, more kind of life-limiting conditions. But some of those low level, especially in early years, and I want to stress that early years, children, and how we make their lives as best as they can in those formative years, we will make a difference later on. That they are not reliant on healthcare services in their or in the ages that we are at and older. But for that to work, it has to be close to where the child is in a community. So at a district level, I think there's a lot we can learn around how we are approaching neighborhood working in the United Kingdom and bring it to that district level.
And do you think we can do that through so the front line being staffed by nurses predominantly? Because I would imagine that the doctor ratio to patient in Zimbabwe would be quite wide. The margins are quite wide, whereas here quite low. So we can actually have devolved systems where you have your GP and you have your nurses. But how would you do that in a setting like Zimbabwe, in an typical African setting, where we know that the staffing levels when it comes to high-level professionals such as doctors is not as quite wide-ranging?
Yeah. So I mentioned earlier about a highly skilled workforce.
Right.
If there's one thing that, speaking as a nurse, Zimbabwean nurses are usually all-rounders. So they know physical health, they've done mental health. What they probably need sometimes is the infrastructure to be able to do the work that they are trained to do. So there's something there about recognizing that we are,
We're training quality nurses, yeah.
absolutely. Now we need to give them the right tools to be able to do this work. There is also the opportunities that using, let's say, quality improvement methodologies might give to those nurses at a district level to be able to do the work they are doing, when they perhaps only rely on one general practitioner and so on and so forth. I also think that we do need to look at all the other disciplines that we can bring around those district at the district levels, the nursing staff and the doctors. So things like social care. We know that economically, many of our communities are challenged in Zimbabwe. But honestly, if we started to try and focus on what else can we be putting around those healthcare professionals that helps people with some of the social challenges that are in existence, we do start to make a difference, especially in those early years. And then I think there is then the bit there about recognizing, and we're doing it here. So you will find that in the United Kingdom now, you've got advanced clinical practitioners, you've got physician associates, and I know there's a big debate on that, but they are highly skilled staff who are being trained to do a lot more, in some cases with less supervision. So it's not every healthcare need that you need a doctor. Doctors are needed, yes, just as much as a nurse. And in as much as I say that it's not every condition or issue that someone can bring to a clinic will need a trained nurse. So we need to recognize that. But for those sort of individuals to be able to do what they can, we also need to be quite structured and be clear about what we are trying to achieve. So I think that the reflection for me would be a much more focused piece of work around being clear on the government strategy and what their ambition is for healthcare for all. And making use of people like myself. I'm not the only one. There's many healthcare professionals in the diaspora. So what can we also start to give back to our country by way of advice, if needs be, or support in other ways?
That makes sense. There's something you mentioned earlier when you talked about making the distinction between primary care and mental health and physical care and so forth. And I'm quite interested in the mental health side of it, given the fact that, the UK, it's really a new phenomenon that you're actually seeing mental health being trying to be placed at parity with physical health itself. Now, if it's happening now in the UK, then one can only assume that the stigma still pervades perhaps in emerging markets such as Zimbabwe. Given your sort of experience in both sides of the point, you know, mental health in itself, are we taking it seriously, do you think, in Africa?
So culturally, mental health will always be a challenge in Africa for all kinds of reasons.
Right.
But I think it's heading in the right direction in terms of people being more confident and comfortable in acknowledging it exists and thinking of ways in which they can start to support and help people who may have a mental health need. The other aspect to it is what I mentioned earlier. There's mental illness and mental well-being. Increasingly, you will find, even in emerging markets, stress can easily take somebody into a dark space. But how equipped are the rest of us in acknowledging that maybe Edwin is going through a tough time? We need to be thinking about how we support him or be kind to him, or even within a family, how do we help? So I think there is the bit of how do we start to transition our communities into looking at mental illness and mental well-being, and how can we start to, I guess, cross-pollinate low-level skills of mental support to not just healthcare professionals in Zimbabwe, but to the wider communities. I think industry has a big part to play. Workspaces, how mental health friendly can they be to a certain extent? And I also think that even in some of our general hospitals, because usually when someone is unwell or you've suffered a broken leg, you know where to go and get help. But sometimes, increasingly, we do find that those sort of events then lead people into mental health issues. So how do we equip staff who are supporting them with their broken leg to have some low level, or even the ability to signpost them to where they can get mental health support?
And I suppose one of the challenges, like for example, quite a number of countries in Africa are having challenge with drug abuse, drug and alcohol abuse and so forth. And it's not seen as a mental health challenge. It's sort of like augmented as its own issue there. And I don't think the messaging, you know, permeates quite well when it's just seen for what it is. Yet if it's seen as part of a broader mental health challenge, then perhaps the seriousness of policy orientation within that context would be more impactful, I think. What's your view on that? Do you think we in terms of the story we are telling about mental health, are we packaging it well, do you think, within the African context? Or is it something that you see that's emerging?
I think it's an emerging sphere of work for all of us. As I mentioned earlier, culturally, mental health, we frown on, there's stigma even to this day. Even in families where you may have people who are considered well-read and well-educated, mental illness has stigma associated.
And we are not unique in the sense that the UK itself has been struggling with the same issue.
Even here. And you could say, you mentioned a very important topic in Zimbabwe at the moment, which is substance misuse. It's also a big problem here. And my reflection, Farai, is that actually even here in the United Kingdom at the moment, post-pandemic, it's probably one of the biggest contributors to general ill health out there. It's just because for many people, substance misuse, mainly alcohol in some instances, is done at home now because of those lockdown years. And then when you look at my country of Zimbabwe and what's going on from the anecdotal stories that I hear, it's a generational issue. There's a certain generation that has managed to get themselves into a place where the use of substances, illicit substances, is an issue. And one can only surmise in some instances that there's an element of self-medicating that's taking place there because of things like boredom. And then in some instances as well is peer pressure. And then in some instances, general lack of knowledge and awareness about the impact some of these illicit substances have on people. But it's not unique to Zimbabwe. It's the same here. And again, I would say, I think, being frank, as a community, and I'm talking of the wider Zimbabwean family now, we do need to start having very honest conversations about the whole culture around alcohol, around substance misuse, and be open and transparent about it. But then we also need to be able to, and maybe that's where the government comes in, to back it up with the right kind of support. And it's not always inpatient care, because I understand for many people, they believe, well, lock them away, put them away, and throw away the key for a few weeks or a few months, it will help them. But as I've said, people end up misusing substances for all kinds of reasons.
So there needs to be a person-centered approach.
Yes.
Yeah. That's good. Now, you've hosted the Ministry of Health from Zimbabwe at your offices at Elft.
Yes.
And tell me about that collaboration and what we can look forward to when it comes to the nexus you're trying to build.
Yes. Yeah, no, we had a really good visit from the Permanent Secretary, Dr. Aspik Maunganidze and colleagues. And for me, it was also the bit of, I'm a Zimbabwean and here are my people. So, it was good. But my organization actually, in terms of global health, they've been in this game for well over 20 years.
Okay.
Our biggest long-running piece of work has been with Butabika Hospital in Uganda.
Okay.
In fact, we've been doing this piece of work continuously for those 20 years, and we've learned a lot. So, I was talking about workforce and how we get, different roles to be doing different things. One of the biggest pushes we've been doing is having what we call peer support workers in our workspaces. And these are people with lived experience, but, they are now members of staff.
Okay.
We learned that from Butabika.
Okay.
This was a community.
So you bring in the community within the trust.
Yes.
I see.
Yeah. So our relationship, or at least the project that we are about to embark on with Zimbabwe, in the initial stages at the moment, supported by global health partnerships, is to, again, look at how do we skill up as many healthcare professionals with some low-level mental health skills. So, as an example, at United Bulawayo Hospitals, they'll be working with the oncology unit there around cancer, around how nurses and doctors working in that cancer unit have mental health skills to support not only perhaps the individuals who may have the condition, but their families, because we know it has a ripple effect, cancer.
Right.
So we'll be doing that piece of work, and colleagues will be going out to Zimbabwe to provide the training, and hopefully as it matures, there'll be that reciprocal learning as well that will come across. But again, I have to stress that, in our experiences of working with Butabika and more recently Kenya as well, because we've been doing something similar in Kenya, it's the reciprocal nature of this relationship that's important. We don't go into this as an organization saying we are going to be teaching them.
You also go there to learn.
We're also going there to learn. And the spirit is shared with the receiving organization and country.
A sense of mutuality, partnership, collaboration.
Absolutely. So I guess, Farai, what I'm saying there is that, in as much as sometimes it feels that some of the health challenges countries like Zimbabwe are facing feel insurmountable, I think there are those of us in the diaspora. It's what we can collectively bring to bear to try and create the right conditions to support this reciprocal learning. I'm fortunate enough to work with an organization that's quite matured in how they've been approaching global health. So I feel I'm contributing, firstly as an employee for my organization, but as a Zimbabwean, there's a personal sense of I am giving something back here as well. So I think, that's a reflection I think I would encourage my fellow diasporians in healthcare to also look at and think about. But I also know that we probably also need to be working perhaps with His Excellency the Ambassador in trying to create the right conditions for people to feel they can be engaged and they can access and support in whatever way they can to projects such as this one.
Well, what I like about that is the underlying philosophy, which is, my first mentor was in communications, used to say to me, when I go back home, I don't go back home to teach, I go back home to learn. And I think that's important in terms of what undergirds the push to, contribute back home. So even as we encourage our diaspora brothers, or those of us that are here that want to contribute back home, I think it's also important for us to look at our skills as capital, but capital we utilize in collaboration, because it's important to understand what the issue is first before trying to support, and the best way to do that is to learn. So thank you for that. I suppose, moving on quickly, I must firstly congratulate you yet again on being honored with an MBE. Now, it's quite a high-level ranking honor, especially here in Britain. What was that feeling like, being recognized by the royal family for your service to the NHS?
Thank you, Farai. I'm still perhaps still in a bit of a daze. It's wearing off now. I only collected
2 weeks in now.
Yes, yeah, I collected on 28th of March. I feel very humbled. I never expected that at this stage in my career, I would be honored. You never know who actually kind of recommends you, but what you do know is that when you get that letter through the letterbox, the feeling is something else, you know. And I don't know on the day it arrived whether it was me or my kids, but somebody was screaming quite a lot for a couple of minutes. But yeah, I feel very humbled. I feel very honored. But I also feel hugely indebted to the United Kingdom, because I think to get to where I am, I've worked with some fantastic colleagues, as I've said, some fantastic mentors in my 25 plus years in the NHS, who've all contributed to the journey. And I think this MBE, it's a reflection on all those colleagues, and more importantly, my fellow diasporans, healthcare workers in this country, that, you know, we are there, we are being recognized, and we will continue to do what's best for the communities that we are now serving in.
And I suppose, now, I know earlier when we were before the program started, we were having a chat about it, and there was this point where, you know, based on your feedback, you sort of felt that there's another side to that particular story, though it's a good story to tell. But the other side being that, you know, given the historical, be it the colonial experiences that Zimbabwe has gone through between us and the United Kingdom, that particular history, an acceptance of such an award would probably be a celebration of empire, one would read it. And I was curious to see what your thoughts are based on people that think that way.
Yeah, no, I've had a few people ask me that question.
Right.
In the early stages, it's been quite difficult to respond to.
Yeah.
But what I have, after a period of reflection, I'm left thinking, and what I would offer as a reflection is that I do not see it that way.
Right.
I actually see it as a recognition of contribution to service to this community.
Right.
I think if it was seen any other way, I don't think I would have been thought of in this way and then been given this honor. That's the first thing. The second thing is that I can't see how we can completely disengage ourselves to the history that has brought us to where we are now. And I say this because I guess for my parents who grew up during the days when, yes, Zimbabwe was under the colonial rule and everything that came with it, it has also made them into the people who they are.
Yeah.
And for me, as I mentioned earlier, my parents, they are my role models. They ground me. They still offer me the wisdom when things are dark. I truly believe that part of those experiences have made them into the people they are today. So I think there's something quite profound about that history that we cannot run away from. And then my final point really is about representation.
Yes.
So I guess maybe I guess for me, if it was still in those colonial days, I might not have been recognized.
Yeah.
But here we are, 2025, I've been recognized, I've been awarded an MBE. It has given me access, we were talking earlier just about, I thought as Chief Operating Officer in the NHS in London, I knew people.
Yeah.
But actually, I'm now discovering that actually there's a whole other spaces that I am now part of. And I'm there and I'm representing. And I've been welcomed. And I'm now able to influence and to be present as well. So so I guess my final reflection to add to that would be that bit about representation for me is about those who come after me.
Yes.
I'm representing what's possible.
Yeah.
And I think I'm also representing what's possible not only for a young, I'm not young anymore, but a black Zimbabwean chap who came into this country and made decisions about life, and here I am. So imagine now for those who are being born and raised in the United Kingdom, the opportunities that are there for them and what they can also achieve by being people who focus on service to the communities and also recognizing the history and living within that context and being able to manage some of those tensions that come with it.
Which is great. I mean, because we can't be captured by our past. What we certainly can do is we can reframe the narrative. We can reshape it to within our own image and take control of that narrative in a manner that we conquer. So thank you for that. Now, in terms of I often think, and it's something you pointed to when it came to when you were talking about when you were talking about representation. Representation is something critical, especially within the diaspora. We come from communities that have had to assimilate at many times and have to find their voice in, be it at a work level, especially in big institutions such as the NHS, which historically has not has learned to be inclusive, as it were, and you are evidence of that. So representation is something large. So to a young person growing up, finding their voice here. Now, Zimbabweans have been here for many years. A lot of African families, some are in their fourth diaspora generation, some are in their second, maybe. In Zimbabwe's context, it would be maybe our second phase, be it those that are now born here, the kids that I have, the kids you have. What is the message for them? What is the message to us, what the NHS used to call the BAME community? I'm glad that that's being phased out. I think it wasn't as inclusive enough. What is the message to the communities that come in here and that are finding it difficult to start? And they're watching this and they're wondering, how did he start? And they've heard your story and they've gained some level of inspiration by virtue of where you are now. What's your message to those young people?
Yeah, good question. I think the first thing I would say is be bold. Life is never easy. But one thing I can tell you is that in as much as it will serve you lemons every other day, learn to make lemonade. The second thing I would say is be conscious and listen to your elders. Being of African heritage, we should understand the importance of that. I think where many young people in our communities go astray usually is the advice that's there is for them to consider. And then if they think it will work for them, they take it on. Majority of the cases, sadly, sometimes don't even stop to think about the advice they're being given. I think it's important that people take a moment to think and reflect. I told you a bit about my story. I was determined to be an engineer, but after some prompting and some advice,
adaptability.
Yeah. And that's because it's coming from a place of wisdom. It's coming from a place of people who've been there and they've learnt a lot. You mentioned the generational kind of growth in the diaspora communities. Each generation has had to learn things. So when they are giving the advice, it's from a place of we've been there, we've done
experiential knowledge.
Absolutely. So I think it's important that for the younger generation that are coming up behind us, listen to the advice, consider it. You might not take it, but at least be respectful enough to consider it. And I can assure you then that things might turn out differently for you. Then my final point really is about I'm standing on the shoulder of giants, many of them probably far more deserving of this MBE than me, but here I am. So recognize what you can also achieve in the years to come, standing on shoulders of others. Make use of that opportunity, don't waste it, and be bold, be bold.
And I suppose I should take this opportunity as the head of the Southern African Times to not only say, to acknowledge the amount of incredible work you're doing in the community, but to equally recognize your colleagues within the NHS who are of Zimbabwean origin and African origin. There was a difficult time that the world faced, a time where we had never witnessed before in generations, and it was a pandemic, a COVID pandemic, in which during that process we lost a number of clinicians who were Zimbabwean, some were of African origin, but mainly speaking directly to your community, the community you were born from, you belong to. We lost quite a number. I believe the number is at above 19. Yes. I think 32 to be exact. And these people were in the front line. During that time, my sister was ill. She was in hospital for 5 weeks. And she received incredible support. And as a result, we still have it today. And I see this interview not only as tribute to your service, but equally tribute to them. And with that, I conclude by saying thank you so much for your service. Thank you for demonstrating leadership within the community. And may it long continue.
Thank you very much, Ryan. Thank you for giving me a chance on this platform. And I'm greatly indebted to you and your time this afternoon. Thank you.
Thank you so much for joining us.